Hi, my name is Alba Azola, and I am very excited to be here in this first A4P meeting and excited to talk about the treatment of POTS. And this is also applicable for people with other autonomic dysfunctions and orthostatic intolerance in general. So today we're going to go over how physicians like me think about creating a personalized treatment plan for the patient. We're going to go over the basics of non-pharmacologic therapy and why it's important. We're also going to talk about comorbid conditions briefly because I want to highlight the importance of identifying some of these conditions as they will be important in the treatment of POTS because they can contribute to POTS. And if they're not being treated, there's going to be really difficult to get the POTS under control. And then we're going to move on to first line medications, how we think about the medications, and also second line medications, and how we kind of think about which ones to choose. It's important to understand the individual symptom profile, which are the symptoms that are most disruptive to the patient. We think about the baseline of function and the amount of activity that the patient is able to tolerate. We also want to think about the patient as a whole and what are the circumstances and what is surrounding that patient. Has this patient been exposed to traumatic medical experiences that have made him feel less comfortable with trial of medications, or have had chemical sensitivities their whole life where they have really weird side effects to medications, which is also super common in this population. Are they working? Do they have to continue to work? Are they in school? Can we modify certain things? What is around this patient, and how treatment is going to work on the setting of all of this that surrounds the patient. We also want to empower and educate the patients because a lot of management of POTS as a chronic condition is really to empower yourself with knowledge, like coming to this meeting, and learning how to navigate those triggers, how to change your energy conservation with pacing, um, how to listen to your body. A lot of the time, um, patients stop listening to their bodies because their bodies are sending them all kinds of crazy signals, and everybody around you is telling you that you look great and that there's nothing wrong with you. So, um, creating that healthy relationship with the body to really listen and understand the feedback that you're getting. Um, and we want to keep realistic goals. Um, Also, this is not a one size fits all. Definitely, um, there are different therapies that are going to be more appropriate for certain patients than others. So just because your friend got started on mestinon, that may not be the best choice for you. So it's really important to know that there's a lot of considerations which with each medication and considerations around what is best for a particular patient. We usually like to start slow and go slow. Not, like I just said, medications are not right for everybody. Um, and we really want to make it a shared decision-making process. We want to explain to the patient what it is and make sure that they're ready to try it. And that it's not a one-way street, especially treating POTS. Um, so non-pharmacologic strategies, I want to spend a minute here because I want to explain the rationale behind recommending this and the importance of it. So we know that there's pooling on the lower extremities, abdomen of blood, which causes decreased return of blood to your heart. Also, patients with POTS have a decreased overall intravascular volume. So overall, they have less volume of blood. Um, and this combined issues um, trigger a sympathetic response when the patient goes from supine to sitting or standing. And there's different places where we can intervene here. So in terms of decreasing the amount of pulling, compression of the lower extremities, postural countermeasures can be really helpful, and exercise. We're going to talk about how we increase that intravascular volume with hydration, increase sodium intake, elevating the head of bed, and exercise. And let's start with the hydration. Basic hydration, we recommend at least 3 liters or 100 ounces of water per day. If you can make it to 80, that's great. We also, with the hydration, recommend also increase salt or sodium chloride with a goal of 6 to 10 grams per day. This is applicable to most patients, but there are going to be some patients that do not or should not be drinking or taking more sodium, especially patients that have um, hypertension at baseline. So those patients that when laying down in bed quietly, their blood pressure is still high. Now, if you're having episodes of hypertension, usually when you're upright or standing, you may be experiencing symptoms of hyperadrenergic POTS. Now, those elevated blood pressures are a cause or a result of that fight or flight response. If we use treatments that are going to help decrease the chances of firing that alarm system, then you're not going to have those blood pressure peaks. So even for those patients, we do recommend increased sodium. I wanted to make a note that we don't only want to increase the sodium, but we also want to make sure that when we take that sodium, there is some glucose with it. That's why a lot of Tri-Oral or Liquid IV or other commercially available electrolyte um, uh, powders and solutions will have sugar. It does help the digestive tract transport the sodium in. So that's important. And actually, I put a detail here that if you want to know if you're taking enough sodium, you can measure your sodium excretion in the urine. This is not recommended for everybody, but just so you guys know that there's actually a way to measure and see how if you're taking enough sodium. Um, Compression, super important, also super tricky. Many of our patients cannot tolerate the sensation of compression. Also, many of our patients have hypermobility, so it's hard for them to don this like super tight compression garments. So we usually recommend 20 to 30 millimeters of mercury, as this is better tolerated than the 30 to 40. We also recommend you don't have to buy special medical approved compression. Even Spanx or Honey Love or any of those commercially shaper garments can also provide the compression you need. Um, so there's many options. Usually the summer is harder. Abdominal compression can be easier for some people. And just so you guys know, there are studies. There's a particular one that comes to mind. Um, that was done in Canada, looking at lower leg compression, lower thigh and abdomen. And the more pressure or more areas that you're compressing, the more more of a decrease in tachycardia with the upright posture, um, more of symptomatic relief. So some compression is better than nothing, but all the compression is very good. So consider kind of getting those compression garments out and getting them in. Postural countermeasures. These are something that most patients will be doing on their own just because their body instinctively wants to um, maintain blood flow to the brain because that's very important. So usually you'll notice that a lot of people sit with their legs twisted like a pretzel or stand with their legs crossed. Also high heels, those activate the calves, which helps bring the blood up. So you probably have noticed that when you're standing in line, it's much more difficult like you just become symptomatic pretty quickly and have to sit down. But if you're walking, it's a little bit easier. And the reason is that your muscles are getting activated and the muscles are helping bring that blood flow back to the brain and back to the heart and then the brain. So sitting with your chest, I mean, with your knees to your chest can be helpful. Here we have Megan, our research coordinator from our clinic, driving with the leg bent. This is helpful for her and it allows her to be able to drive longer distances. Um, so use your muscles as a pump. Another quick one I wanted to mention was using a tall stool for cooking can be helpful. It usually requires the legs to be active and it can be a great way to modify and be able to do those things that require standing. Another one that a lot of people forget to implement is elevating the head of bed. Um, this is actually a picture from a paper from 1944, which described this. Um, it actually has an effect in the overall blood volume by elevating the head of the bed. It decreases the amount of filtering that your kidneys do. So you actually end up filtering less blood and producing less urine, which means that you're going to have more intravascular volume. So again, you don't want to elevate just the head or the upper half of your body. You want to elevate the whole bed, and you want 6 inches at least. That can be achieved with usually blocks on the feet of the bed. That's a good way to do it. Physical activity, we know that there's extreme benefits to physical activity with POTS. Um, Certainly benefits in increasing the overall blood volume and also increased tone, cardiovascular conditioning, and ability to pump that blood back up to your heart. So we want to avoid excessive bed rest, but we have patients that are very impaired, that are their level of physical activity, it's going to be very different. So the idea is to do as much activity as possible given your level of function. And for some people, that will be sitting up at the edge of the bed for a few minutes. And for others, it will be taking a walk or going swimming. So it really depends on each person. Starting with recumbent exercises, it's going to be very helpful. It will allow you to focus on strengthening core, strengthening cardiovascular conditioning without the challenge of being upright. Being upright is a very big stressor for your body. So trying to start by walking or running, it's going to be much more difficult than trying to exercise in the floor, using a recumbent bike, for example, or a rower, or swimming. Um, so these are ways to modify the activity so that you can tolerate and you can actually get a little bit more conditioning as well, which is important. And really avoid any rigid advancement of exercise. If you're doing a protocol that requires you to advance exercise every 5 days or every whatever it is, 10 days, and your body's not ready for that, you have to be very flexible and you have to adjust to what your body can tolerate at any given time. And sometimes we need to do some treatment before starting activity or physical therapy. Many of our patients actually start with manual forms of physical therapy, which can be really helpful for neural tension and other issues that patients have, including myofascial pain syndromes. So there's a lot that can be done with manual PT that can be helpful and can allow you to kind of bridge into more activity. There's going to be another talk today, or I think tomorrow, about triggers for POTS. I just wanted to highlight that it's important to be aware of what your triggers are and learn how to modify them, avoid them, prepare for them, whatever it is that you need to do. So, important to know that it can be triggers from the weather, it can be specific foods, it can be alcohol. So you'll hear more about this later on. And also, cooling garments can be really helpful. Most of our patients are very intolerant to heat. The autonomic nervous system helps us regulate temperature. So once our autonomic nervous system is dysfunctional, you are functionally a lizard. You need to modify your environment to be able to regulate your temperature. So this type of assistive devices can be quite helpful. Um, and I am not going to spend too much time in this slide, but I just wanted to make a point that when we're treating POTS, we need to think about all the other comorbid conditions that could be contributing to symptoms. For example, people with mast cell activation or significant allergies, those reactions can certainly trigger release of vasodilators and make the POTS worse. So doesn't matter how much POTS medications you're putting in, if you're not treating the mast cell or if you're not treating those allergic responses, you're gonna be having a harder time taking care of your POTS. So this is a whole nother lecture for another day, but um, an important point I wanted to highlight. We're going to talk about kind of first line medications, and there's a typical three medications that address three of these mechanisms that are contributing to the POTS, right? The pooling, the decreased volume of blood, and the sympathetic response. So we're going to intervene with the pooling using vasoconstrictor. Midodrine is kind of our first line vasoconstrictor. We are going to try to expand your volume using fludrocortisone or Florinef. Um, this one increases your retention of sodium and water and it expands your volume. And lastly, we're going to use beta blockers as our third kind of first line medication. Beta blockers are medications that block that sympathetic response and decrease the brisk jump in heart rate. Um, so we're going to dive deeper, but these first line therapies are not the only ones that intervene in this particular pathophysiologic contributor. We also have medications like dexedrine, methylphenidate, which are not only helpful for the brain fog, but are great vasoconstrictors. We have medications like droxidopa, which has approval from the FDA for use on Parkinsonism and people with orthostatic hypotension from Parkinson's. Um, However, we can use it off label for patients as well. So SNRIs and SSRIs have a similar effect. For volume expanders, we talked about salt, and salt tablets can be used. Um, Occasionally, in very debilitated patients that have extremely poor orthostatic tolerance, can consider IV fluids to volume expand. But fludrocortisone is our first line one. Clonidine and oral contraceptive pills are also effective in volume expansion. And also desmopressin or vasopressin. This is a hormone that allows your body to um, kind of retain water, but it's free water without sodium. Um, Anyway, for the blockage of that sympathetic response, we talked about beta blockers, but I want you to know that there's other options too, and we'll talk about some of these. Let's discuss midodrine. And midodrine is an alpha agonist. So it goes only to the periphery, right? So it doesn't go into our brain or our spinal cord. And what it does is that in the periphery, in our arms and legs, it'll tell the blood vessels to contract. This reduces the pooling and tends to reduce the amount of symptoms. So it prolongs the time that you can tolerate upright posture. Now, it does increase blood pressure, right? It's constricting those blood vessels. So one of the risks is supine hypertension. And something that I hear a lot from my patients is this terrible fear of laying down. And I just want to put that into context. So when you take your midodrine and your blood pressure usually is in the hundreds, this medication is not going to raise your blood pressure enough to bring it to 160 systolic. Like, it's going to be okay. You can sit down, you can recline. Um, However, if you're going to spend the Sunday in bed, a lazy Sunday, don't take your Midodrine. So just be a little bit more flexible about that. I just have heard a lot of like extreme concern, and we can have a little bit of flexibility around that. Itching is something that some of our patients complain about, some numbness, scalp tingling and goosebumps are almost kind of expected side effects. These are usually well tolerated, but some people will report that it's too much for them, and it can be limiting in terms of up titrating the medication. And one thing that I wanted to highlight was the urinary retention. I see this mostly in males, but I've also seen it in females. What happens is that there are alpha 1 receptors in the sphincter of the bladder, which is kind of that outlet of the bladder, and it just tightens it up more. So now the bladder has to push against a tighter sphincter, and it makes it difficult to fully empty the bladder. So we can see some retention of urine. Um, Important to let your patients know, because sometimes they won't volunteer that information. So just important to for you guys to be aware and to make sure that you tell your doctor, because sometimes physicians won't ask about it um, either. So if you notice anything like that, mention it. We usually start at 2.5 milligrams 3 times a day, usually 4 hours apart. Some of my patients uh, find 2 doses a day better for them, or it's hard to comply with all 3 doses a day. So there can be a certain flexibility with this medication. It's kind of an on-off medication. You don't need to be weaned off. Necessarily, it's not dangerous. So it's just a good one for patients to kind of learn what works best for them. I have patients that will do 10, 7.5, and 5 milligrams, instead of doing the same dose 3 times a day. It can be titrated that way in order to help you with whatever it is that you want to achieve. Some people may need to take more than 10. I don't do this very often at all, but it can be done. Another first-line medication is fludrocortisone, and remember, this one is for volume expansion. This is a mineralocorticoid steroid, so it's actually produced by your adrenal glands naturally. And it is a steroid, but it's very different in terms of what it does in your body to a prednisone or another steroid per se. However, it's important to know that it does have some of that effect. The brand name is Florinef, so I usually call it Florinef. And what it actually does is that it tells your kidneys to retain the sodium, and in exchange for the sodium, it sends out potassium. So it's going to increase the amount of potassium that you pee out. It's really important that when you're taking this medication, you're drinking enough and you're taking enough sodium in. Those things are key, because if you don't drink enough and take enough salt, the medication's not going to work as well. Another important thing is that if you are not repleting that potassium that you're peeing out, you're going to become hypokalemic, which means low potassium in your blood. And that is actually a risk. Plus, your kidneys are super smart. So if you start getting low on potassium, it'll stop letting the medication do its thing. So actually kind of stops working. And that's another reason why sometimes people feel like, oh, the Florinef is not really helping anymore. And sometimes adding more potassium to the diet can actually help again. So important to think about those things with this medication. Usually it's taken once a day, but you can split the dose. Now, be mindful that evening doses can cause insomnia. Other side effects that it tends to cause is headache. I've seen this a lot with my very migrainous patients, but not all of them. And you can also get acne from it and fatigue. Like I mentioned, low potassium is a big deal. We want to make sure that we're checking our potassium levels, every 6 to 12 months, depending on how long you've been on it. Um, you want to make sure that you are not raising your blood pressure too much, right? So if your blood pressure baseline is in the 120s and you're taking fludrocortisone and then you're doing also midodrine, that may bring up your blood pressure enough to be too high. Um, so yes, we want to make sure that we're not at a high blood pressure. And initially in the treatment, you might want to check periodically your blood pressure to make sure that you're not overshooting. I mentioned about the diet of supplementation of potassium. I usually prescribe potassium supplements to my patients on Florinef. You can also do it by dietary potassium, but it is something that is important to do. Licorice root, which is the supplement that's commonly kind of thrown around in the pot circles. This has a very similar effect to fludrocortisone. So if you're doing fludrocortisone, you may not want to add that licorice roots because it's too much of a blood pressure elevating effect. And with fludrocortisone, we know how much you're taking, but with the licorice root, you're not really sure. It can just elevate your blood pressure too much. Also, in people who have sensitivities to dairy protein, the actual pill, most manufacturers make it with lactose powder. So if you have a severe reaction to dairy protein, you may want to have this medication compounded. Um, also, our third first line medication, which is the one that's going to temper down that sympathetic response, is the beta blocker. It lowers the heart rate and it also decreases the forcefulness of the contraction of your heart. Some of the most common side effects are feeling dizzy, lightheaded. It can bring down your blood pressure, so that can further, in some cases, further worsen the orthostatic intolerance. It can cause low mood, and it can also mask symptoms of low blood sugar. And in patients with asthma, it can worsen bronchoconstriction. So those are things to be mindful. Now, we want to start low and go slow, as we always say with this medication, since our population is very sensitive, and particularly with beta blockers, less is more. Lower doses help us just bring down that tachycardic response without lowering the blood pressure. Now, like I said, some of the beta blockers are specific to the heart and some are not. So propranolol, for example, is non-selective. So this one can cause those pulmonary side effects for those asthmatics. And so we want to be mindful. So in somebody with asthma, you may want to take atenolol or metoprolol or bisoprolol because those are more selective. And usually these are dosed daily or twice daily. Um, I made this little chart so you guys could get a sense of the different considerations with each medication. And I want to talk a little bit about second line medications in the last minute. We have pyridostigmine or mestinon. This is a medication that is pretty scary to prescribe as a doctor, so don't be mad at your primary care if they don't want to give you mestinon, because I started giving every single patient that I put on mestinon, giving them my cell phone because it was very scary to me. There's some evidence that it can be really helpful in improving activity tolerance in MECFS patients. This medication is an acetylcholinesterase inhibitor. So it basically inhibits the enzyme that breaks down acetylcholine. Now, acetylcholine is a neurotransmitter, and it's found in the neuromuscular junction, which is where your nerves tell your muscles what to do. Now, when this medication was first designed, it was created for people with myasthenia gravis, which is this disorder, an autoimmune disorder that attacks the neuromuscular junction. So it doesn't allow the nerve to tell the muscle what to do. So we are repurposing this drug to use it because there's acetylcholine in this autonomic nervous system. Now, we want to make sure that the patients that we're selecting for this are appropriate because the side effects are significant. You can get muscle cramps or twitching, nausea, vomiting. Typically, diarrhea is one of the most limiting side effects. Bronchospasms can be significant enough to put somebody in the hospital. And I say that I learned this the hard way. So it's a tough decision to make, but I've just kind of overall, if you have any asthma, childhood, exercise asthma, I just don't give you Mestinon. It's just too high a risk. So if you're constipated, this is great. It'll help you go to the bathroom and hopefully it'll help your orthostatic intolerance and your activity tolerance. We start low. Some people, I usually start at 30, but in some chemically sensitive people, I'll start at 15 and titrate to 3 times a day. 60 milligrams 3 times a day is usually the goal. If that is going well, I change to the extended release, 180 milligrams daily. And this is nice because it's only once a day and you don't have to worry about it. And you don't have a lot of the ups and downs or the GI side effects, the queasy sensation you feel in your stomach after taking the immediate release. Another second line medication that we commonly use is ibabradine or Corlinor. Corlinor was created for heart failure for patients that needed to have a slow down of the heart rate, but also had low blood pressures. So we use it off label for POTS and for an appropriate sinus tachycardia because, again, it slows down the heart rate, doesn't touch the blood pressure. So it's ideal for those patients. We start low at 2.5, then we move to 2.5 twice daily and titrate up to a goal of 7.5 twice daily. Now, I want to make a small caveat here. It's not in the morning and at night, it's in the morning and midday. If you take it at night, you don't need to lower your heart rate at night. That's usually pretty good. You want to lower it during the day. So you take it first thing in the morning and maybe around 2 or 3. We also sometimes go even higher to 10 milligrams. And in my group, we usually do not go higher on the dose if your heart rate starts dipping below 60. So one of the problems with this medication is that it can cause symptomatic bradycardia. It can definitely lower it enough that you can become symptomatic from that low heart rate. So you want to keep the goal of low 60s at rest. At night, it's a little bit different. You can have lowers at night, but during the day at rest, you want it to be around 60. Expected benefits are improving that tachycardia, but also improving the exercise tolerance. And I really see in my patients, they're able to kind of do their morning routine without getting into the 150s or 160s. So it helps them kind of tolerate more activity and they're less limited by the palpitations and tachycardia. A funky side effect that it has is that it causes visual halos, usually around like light, fatigue, lightheadedness, nausea, headaches. Those are a little bit less common, but the halos are definitely there. People usually get used to it. But yeah, be aware that that happens usually about an hour after taking the medication. Another funky thing about Corlinor is that it's metabolized by CYP3A4, which is a very common enzyme. And by I mean commonly metabolizes other medications. So if you're using ibabradine, you have to be careful about interactions with other medications because it kind of changes the way this enzyme works, and it can change the levels of medication in your body. Um, Contraindications really, a heart rate less than 60 at rest. Like I said, not sleeping, but just as rest. And we don't recommend using it with calcium channel blockers. You can use with beta blockers in certain cases, especially those people that have underlying arrhythmias like ventricular tachycardia or supraventricular tachycardia. Those people are not going to get a control of their rhythm with ivabradine. They're going to need the beta blocker to control their arrhythmia and the ivabradine on top, to get rid of the big spikes in heart rate. And this is a beautiful table from a nice paper. Dr. Blichstein is the first author, and I was involved in writing this paper as well. It really kind of has the collective wisdom of a group of people that have been treating this patient population. And we created it so that primary care physicians could read it and learn how to work up the person that presents with this autonomia, how to make sure that it's nothing bad or nothing that needs to be treated differently, like, with an ablation, for example, and, how to navigate the treatment and initiation of treatment. So I recommend sharing this paper with your doctor if you want them to have a good guide on how to manage this. Other treatments that I wanted to briefly mention were more exploratory. At this time, there's not a lot of strong evidence supporting them, but I just wanted to make you guys aware of enhanced external counter pulsation, um, which is a specialized kind of compression system that brings the blood up. It coordinates with your heart rate. There's vagal stimulation. They have devices that you can buy and try at home. Cold plunge. I would never do this, but a lot of my patients find this super helpful, so I'll mention it. Parent technique is a manual physical therapy technique. Stellate ganglion blocks, those are usually performed by interventional pain specialists, and usually ultrasound guided in the right hand, so it's very minimal risk. I have had patients find it super helpful and lasting more than 6 months, and I have patients that didn't feel any better after the stellate ganglion block. So it really depends. There's a lot of variability between people. And hyperbaric oxygen, um, again, limited evidence, but just wanted to put it out there. And that's it. Thank you so much for this opportunity to share with you guys. And I want to thank all of our funding and our wonderful patients that do so much fundraising and help us maintain our clinic open. And you can reach out through Twitter or email. Thank you so much and have a beautiful day.